So today we have Dr. Mike Epton and Dr. Hilda Mulligan from the WellConnected New Zealand project, based in Christchurch, New Zealand. This project centres around community connectedness and the way that impacts people's health and well-being. Could you each begin by telling me a bit about your background and where your ideas were coming into this project?
The journey from my perspective is as a specialist who works with people with lung conditions. I was really frustrated that we put in place very effective, evidence-supported rehabilitation programs that people just don't get to. They don't get referred to it, and when they are referred to it, they don't come. That actually only about 1% of the people who would get benefit from these rehabilitation programs are actually referred. So there's this huge gap between the people who would get benefit and the people who were referred, and we wanted to try and understand that. Some of it relates to people not actually being referred by their doctors, and that, at least in part, is because people are not necessarily coming to the doctors with this particular problem, or the doctor, trying to deal with the whole load of things for that one person, forgets or actually doesn't think about rehabilitation, and that lowers the priority for a person being referred to a rehabilitation program. Of the people who are referred, only half of them actually turn up. So in spite of us having all of this really good stuff that we've put out there, people are not coming.
And my background's in physiotherapy, and I've had many years working with people with long-term conditions and disabilities. What I've learned over this time is how people with disabilities don't want to be seen as their condition, and yet that's how they seem to be seen by the health system. Besides that, they don't want to be seen only as requirers of support. They don't want, they're always told they need support. They actually want to have agency over their own decision making. They want to be able to look after their own health and well-being. They want to go to recreational activities and social activities just like everybody else, not for therapy, but just because that's what you do. And actually I can understand why they don't go to condition-based programs. They've told me they don't identify with other people who attend the programs. They might be younger or much older than those people. They have different interests from those people. They don't necessarily have the same interests just because they have the same condition.
So how did you two get together to begin this project?
I met Mike because he was looking at ways to make rehabilitation programs for people with pulmonary conditions more user-friendly, and especially the assessments that they use for these people. So we met doing some small research projects looking at how to make the assessments more comfortable for people.
In getting to know Hilda, I learnt that her research supported a different way of thinking to what we call the deficit-based medical model, i.e. you, the patient or the person, have needs, and we, the system, the healthcare system, are there to support your needs. That is what we call deficit model thinking. Together, though, we thought about having a different way of thinking and how that might impact on-service delivery, particularly around rehabilitation programs. But these programs are not necessarily just for people with lung conditions, but for people with other long-term conditions.
And what has the journey been from there?
So when Mike and I originally got together, the project was, we thought we would like to develop a generic rehabilitation program instead of single condition-based programs in Christchurch where we work. However, we foresaw barriers to a generic program because currently condition-based programs are funded for people with a specific condition. So for example, the Arthritis Foundation provides rehabilitation for people with arthritis, the Cancer Society supports people with cancer, there are programs for people with respiratory conditions and other and different programs for people with Parkinson's. So we decided that through this research we would like to ask people themselves what would enable them to have control over managing their condition, control over how they access services, what were their priorities, what does support mean to them, what does it look like, and how would social connection fit into their lives.
And we know from research evidence, and actually we can all intuitively understand, there's a correlation between an individual who is lonely, who is socially isolated, and that individual's health and well-being.
So we've now talked with lots of people, not two people, but with them. They've ranged from people with long-term conditions themselves, talking with them in their homes, talking with them in their community settings, in maraes. We've also talked with a lot of health professionals. We've talked with counsellors, architects, transport planners, non-government organisations, and actually the government too. So it's been a really wide consultation, and it feels like it's been a building of research together with people to whom this matters. The people we've talked with are part of the research. We're not looking at them from the outside. They're all part of this Well-Connected project.
What then happened is that we kind of assumed that there actually wasn't much going on in people's communities. Particularly post-earthquake in Christchurch, we were concerned that there wasn't much and that we needed to support the creation of some of these community programs. But actually, what then turned out when we actually asked the people in their communities is that there's a whole load of stuff going on that potentially, by linking people up with those activities, it wouldn't necessarily be seen as health activities, but by linking people up with those activities, health benefits flow on from that. So it then became a question of understanding what is already in people's communities. How can people be linked when they've lost those links, when they've become isolated? How can these people with long-term conditions be effectively linked into their communities?
Right, so you were wanting to link people into the already existing community groups rather than creating a generic rehabilitation program that could be offered around Christchurch.
Yeah, absolutely. So as well as that, we also identified the concept, which is already there, which is of community champions. So these are people already doing things and supporting others in their communities. And rather than setting programs up, there needs to be more support and linking of individuals into their communities. Some of this can be done by the local champions. At the end of the day, it's about having people with long-term conditions who have become socially isolated, linking them to the programs that are going on within their own community. And that will have health and well-being benefits that can then flow on into the healthcare system. And it's about doing this in a way that we, the healthcare system, are not the ones that are in control. That healthcare providers are not the people prescribing this. That we're not even the people telling people what they need to do. That we're actually purely acting as supporters and link points.
Yeah, I agree. We see an important role of the project as brokering the links. And we know that if people have control and choice over what they are doing, they will continue doing it. That became very clear in my earlier research, that people would find their own way through things even if there were challenges in the way, if they were doing something that they enjoyed and wanted to do instead of something that was prescribed to them.
So how do you link communities to these local champions that you're mentioning? How do you help to support that?
There's a whole load of ways. Everyone actually wants to link other people with technology these days. And we've explored some of the technologies. And at the end of the day, our discussions with some of the communities resulted in, if we're going to have technology, it needs to have a human face associated with it. That trying to set up apps and smartphones that will replace communities is not the way to go. That actually technology is there to link someone to a human face. We distilled down a whole load of discussions about technology and came to the concept of an interactive map. So the map can be online, but it can also be printed out, so that people can then use that technology in the way they want to. That map is essentially bringing together a whole load of resources, council, health-related, social resources, all in one place. So that people can say, where do I live? What's around me? It's based on Google Maps and it's interactive, so people can find what's going around me and then they can make the choice about whether they go to it. And then the map can then support that because it links people to the person who's organising that particular activity, whatever it may be.
So you're saying the choice comes down to the person rather than having someone prescribe it for them?
Yes, absolutely. One of the really useful things about this map is that everybody, including healthcare workers, can use it. Because healthcare workers in their communities don't necessarily know what's going on around them either. They know all the health-related stuff, and actually not even all of that. But actually knowing that there is, down the road, something that might ring the bell in terms of a person's health and their well-being, and actually using a map to trigger that kind of conversation. That's the way we would like to think that healthcare workers might want to use a map like this.
And so for the healthcare worker, instead of saying, why don't you go to, you could say, is there anything here on this map that interests you? How do you think you might get there? Who might you go with?
Do you have any stories you could share of how a community link has flowed into a health outcome?
So you have the situation where someone's new to an area or is socially isolated or disconnected. They get involved with a local community group. And as part of that, at some point, a healthcare worker links with that same community group and ends up offering or suggesting flu vaccination for that group. So this is a group of people who may not necessarily go to their doctor or their healthcare worker either, because they don't know where they are, where the doctor is, or they've just moved into town. There's all sorts of reasons why people don't actually go to their doctors, and yet vaccination is such an important part of keeping well in the community that you have an opportunity that when someone comes to a community organisation and the healthcare worker drops in and says, well, what about the flu? And suddenly you have a bunch of people who are vaccinated, who would otherwise not be, because they would normally not go to their own doctor to have that done. And that's a triumph. And you can have those kind of interactions between healthcare workers, whether it's well-being, whether it's more specific health issues, vaccination programs, stopping smoking, alcohol and drug discussions. There's a whole load of ways that this could work. But the point is, it works because there are a bunch of people getting together in a community activity, and the healthcare worker drops in, for the want of a better term, rather than, this is all organised by healthcare workers and you should come because it's good for you. That's not the way that it works. And we think this is going to be a very effective way of providing very important healthcare, whether it's exercise, smoking cessation, vaccination. These things are huge in terms of their impact on people as a whole.
And even the impact of somebody getting together in a community group will have a flow-on effect to their health and well-being, even without a health professional visiting that group.
Healthcare doesn't necessarily begin at the doctors for a lot of people. A lot of the way that the health service works relies on people currently interacting with their practice, their medical practice, with their GP. And that's actually really very good, because the GP practice in New Zealand is a core component for healthcare delivery, but it's not the only place where people can or should access health. If we can seed healthcare messages into community interactions, then as a healthcare system we'll probably do better that way. We have to understand that we're going there with permission. We're going there on the understanding that we're not the ones in control here. This is a community organisation, whatever it might be. We're just there to add our bit. But we're not the most important bit of that community and what goes on in that community. We're just in there to add a little bit of what we believe is value.
And it feels as though you're focusing on the whole person instead of perceiving them by their condition.
Yeah, exactly. We're focusing on the person in their own context, their own wishes, their own preferences, how they want to do things, what they can bring to the situation, how they can look after their own health. We're looking at their strengths rather than the deficits. And most people are able to look after themselves, care for themselves, be in their communities, be a useful part of their community, and to give and receive from others in a meaningful way. And that's actually what people want to do. So yes, it's a much wider framework of looking at people.
We had this lovely phrase that someone gave us very early on in this research. We asked them, what is a community? And that person said, young people and old people helping each other. What it implied was that we've always assumed within healthcare that people with long-term conditions, particularly elderly people with long-term conditions, need our help. What we forget is that they can give as well as receive, and that the giving in a community is actually very powerful in terms of health and well-being. That if we just assume that people have needs and the healthcare sector is designed to provide for those needs, then we forget the benefits of giving that people with long-term conditions can have. So our whole concept of community is saying this is a give and take process. This is not saying you as the patient receives, we as healthcare providers provide. That's deficit model thinking, and that was a very powerful message we got really early on in this.
So you mentioned earlier that you spoke with a wide range of people as part of this research. Can you tell me how people were chosen for that research?
It's funny because everyone assumes that research projects have specific participants. We've been looking at the eastern suburbs, particularly the eastern suburbs of Christchurch, and there's a lot of historical reasons for that, and especially post-earthquake. We thought that we were going to see an absence of services. So for the better term, our research population for this study is the communities of the eastern suburbs. But interestingly, as the research evolves, we recognise that there are other groups who actually are research participants. For instance, understanding how work like this can alter healthcare workers' attitudes and approaches is actually a research outcome. And even bigger, understanding how funding systems and the way that money is directed into healthcare can alter responses and how we can change that is also a research outcome. So if you're actually looking at it in pure research sense and you say who are the research subjects, the answer is society in all its manifestations, and that's quite interesting. Hard to do the research, but quite fun.
So you're looking at not only community, but systems and relationships.
Absolutely.
Yeah, and when we think about systems as health researchers, we would be assumed to be looking at the health system. But actually we've discovered that it's much wider than that. It's not just the health system, it's community systems, social systems, technological systems, funding systems.
The built environment, transport, and this is what makes a community. That if you just focus on health, you miss the point. And this is where the research has gone. We're not just focusing on health outcomes, we're focusing on societal outcomes, on technology outcomes.
And in terms of outcomes for this project, you've talked about the map, which sounds to be a hugely important tool. Do you have any other outcomes in mind for this project?
As time goes on, we'll have a lot of social media and media outputs. So whether that'll be websites, Twitter, Facebook, print media, and the more formalised academic publication outputs, all of these are important in making change. One of the things that we know, particularly within healthcare research, unfortunately, is that the traditional model of disseminating outcomes, which is usually through academic papers, doesn't make big change quickly. So we're looking at all of the ways that we can disseminate ideas and understand which of those is going to be the most effective at making real change. And print media, social media, broadcast media are likely to be more effective than academic journal outputs.
Yes, and in terms of outcomes, one of the stories that we've heard from health professionals is, wow, just in talking to you about my service and how we do things, I've realised that that's not perhaps the most clever way of doing things, and I'm going to go and have a look and see how we can make changes.
And one of those stories is from me, from us. We started off with preconceived ideas at the beginning of this project. And now, as part of this process, that we realise that those preconceived ideas are not necessarily correct. And that's the process, that by interacting and discussing, you mould your ideas, you generate agreed outcomes. Some of those are technological, some of those are community, some of those are philosophical.
And it's been really humbling to sit and listen to people talking about their health services. Lots of health professionals would like to change the way they offer services. They can see that the way health services are offered can be improved, and they can see ways to change this. And just by allowing them to talk about it, they come round to see small changes that they could make straight away.
So what would you like people to take away from this discussion of the WellConnected project today?
So we've come to realise that communities, and in particular healthcare communities, should focus less about barriers and think about solutions. To recognise that quite a lot of people want to make change, but for all sorts of reasons, each of us and every system has barriers. Either people have put those barriers up, or the system has put up barriers around them, and they have great difficulty overcoming those. We believe a lot of what we've been trying to do is about permissions, that people have the power to think about solutions instead of thinking about barriers. And that's been very empowering for people who've already interacted with this project. That people have been thinking, what can I do to make a change in my community, whether that's a social community, a geographic community, a healthcare community. And that's very powerful because we tend to assume that we can't make change, that there isn't funding for this because of X, Y, and Z, or the computer says no. There's a whole lot of reasons that people give, but looking for solutions rather than barriers has been a major part of this project.
Well, thank you both for taking the time to talk about the WellConnected project with me today. If you are interested to learn more, you can head to the website on www.wellconnectednz.org, where I believe you can also check out the interactive map straight from the website.